and welcoming all the audience who have joined with us today. There's a big number that I see, and I'm sure more and more are likely to come. My job here is only to welcome all of you and then hand it over to Anchita. I would like to tell the audience that this topic has been chosen. It is at a very good time. There are a lot of women here that are career oriented, and often questions come. Do we have a child now? Do we have a child later? Does aging affect our childbearing capacity? Is it only men, or is it only women who need to worry about it, or does the male partner also have to contribute to this issue of should we have a child now or later? In the early days, we knew that girls that just had got into menarche would be married, and then they would have their first child right as early as 14, 15, or 16. That's not the India we are in today. Today, women would like to have a career, postpone the childbearing to much later stages. So this is really very good time for all of us to discuss on how does aging affect our ability to have children. And so today's topic is very apt. The topic is on myths, facts, and science of reproductive aging. And we couldn't have asked for a better panelist than this, a researcher, a clinician, and a technologist. And the combination is going to be fantastic. Over to you, Anchita.
Okay. So, yeah, I hope this would be a very enriching discussion. So firstly, so as soon as I thought about the title, the very first question that came to me was whether reproductive aging affects both men and women equally. So as Anu ma'am already mentioned, so for most of the, let's say, infertility cases, it is always the women's age which is highlighted. So is it because women are more prone to aging related impact on the reproductive system? Dr. Lavanya, would you have, what are your thoughts on this?
I think it's first of all to say I would congratulate IISc for this wonderful initiative. Like Anu already mentioned, I think it's a great topic that you have picked on. Understanding why I would say it's a great topic, because in my clinic I see that a lot of couple are postponing their pregnancies for several reasons. Of course, in the modern technology, we need to acknowledge and respect their own decisions. But then we as a clinician, as a researcher, or as a medical technologist being in this field, how do we support these people to be peaceful and continue to plan their pregnancy at their comfort? And that's what is more important. And I think that was what going to help all our people who have delegates who have logged in today. So initially, when you and Anu were saying, is it like the male or is it the female? I think it's very important for us to understand that it's not only the females who are contributing to the infertility sector. I would say 30% comes from the female, 30% is male, and 30% both of them contribute to the fertility factors. And forbidden, we do have something called as unknown explained infertility, and that contributes to almost 10%, where we have done all investigations, everything on the outlook looks good, but we are not able to explain why this couple are not going to conceive. So it's very important when we are talking about fertility, we address both the male and the female. But then with the female, age remains important because we all come with a fixed number of eggs. So as the age increases, the number of egg reserve comes down. So it's like simplest of the thing, when we are a baby in the mummy's tummy, we have 6 to 7 million eggs at 5th month. So by the time this is reducing to almost 1 to 2 million. And by the time we attain menarche, it's coming to 40,000. Of which only 400 is getting ovulated. So imagine what happens through your age when you're 20, when you're 25, when you're 30, 35, 40, it's depleting continuously. So it's like a dynamic process which is working in your ovary. And this is exactly why a clinician would tell you, please try to conceive at the earliest. And not only in terms of fertility, also with the increase of age, we also have to understand there's a high chance of Down syndrome. Down syndrome is to do with mental retardation. So earlier you conceive, it doesn't mean it's zero risk when you conceive at 20. It is just that at 20, the risk is 1 in 1,500. At 25, the risk increases to 1 in 1,000. And then it becomes 1 in 500. At 35, the risk becomes 1 in 500. Then the risk becomes 1 in 200. So your risk increases for having an abnormal child. So this is why we say, plan your pregnancies early. And this is why I would say age matters a lot for female. And yes, to a certain extent also to the male, because you develop atherosclerosis where the blood flow to the testis is much lesser. You end up having erectile dysfunctions. You also end up having a lot of medical disorders like hypertension, diabetes, where the erections may not be good, and where your semen quality can come down due to medical factors. So age is a factor for both male and female, and I think it's very important for both of them, and it's very important to timely plan it.
Yeah. Dr. Malini, would you like to add on to that?
Yeah, so first of all, a big congratulations for coordinating this event, dealing with all of us, Anchita, and finding an appropriate time when all were available. So, you know what Dr. Lavanya said, very true. Women has the kind of major burden because the ovarian reserve is limiting. And also, along with the reserve being limited, the quality of oocyte also goes down with age. So that's an important factor. And the gap is that the male part has not been studied much because the male also contributes a lot. So the quality of sperm, the Sertoli cells start aging, the motility of the sperm comes down. So these are factors which are critical, and largely ignored kind of fact is that many recurrent failures or abortions which occur in women are because of the male sperm. Now people are trying to work on paternal factors of infertility. In that, something which has come up is the abortion rates or preterm birth. All these are affected by the sperm quality also. So that is something new which is coming up, as well as the offspring can have defects from aged males. So these are things which now we also need to put in the counsel people that these are other things. And an important factor when we talk about why this age change, career is one, but I would say that along with career, the current IT sector people, they're all working late in the night, so that is causing a very big derailment in their circadian rhythm. And we have shown that is probably leading to a higher PCOS. Male, again, not much work has been done. But there are now others also trying to show that, so when you don't sleep, male, I would say like this, they become obese, they will get diabetes, and then obese, both men and women have infertility issues. So that is why, I don't know whether you guys heard in the news, Ozempic babies, that is people who were taking weight loss drugs, there was an improvement in the fertility. So therefore, I am more concerned about the IT sector and our younger generation, because they are undergoing a lot of changes in their body and a lot of issues coming up with them.
Yeah, that is very true. Mr. Varun, so do you think that the diagnostic tools like your company Inito develops, can that predict the onset of age-related fertility decline? Like, are you developing something that would also not only a fertility test kit, but also something that would predict on the basis of age whether the fertility happens or not?
Yeah, thanks, Anchita, for setting this panel up. It's very nice to be a part of this. And yeah, hi to Dr. Lavanya and Dr. Malini. Yeah. So yeah, this is a very apt question actually. Uh, we just discussed the male factor and the female factor, right? If you break down infertility, right, there are so many lifestyle and age-related diseases or conditions, right, like PCOS, primary ovarian insufficiency, luteal phase defect, implantation failure, and from the male side, sperm count, motility, morphology, and then chromosomal defect. So all of these are like different manifestations which can decrease the chance of getting pregnant and live birth and so on. Now, one of the tests that Inito is working on, our first test really, is a single test that can measure 4 reproductive hormones quantitatively, which can be taken at home. And the idea of a home test is, throughout the cycle, you can take multiple tests almost on a daily basis and then map out all the events that are happening in the menstrual cycle. Like, for example, at the onset of the cycle, right, your FSH is supposed to rise, and that's what kind of causes the follicle growth. And then once the follicle starts growing, your estrogen is supposed to rise. And when the follicle matures, your estrogen almost peaks. And then, there's a sharp LH surge that's supposed to happen. And once your LH surge happens, right, that ruptures the follicle, releases the egg, and then the remnant of the follicle is the corpus luteum. And the corpus luteum releases progesterone. And now we've built tests that can measure all of these parameters, right? Because all of these essentially will lead to releasing of specific hormones of FSH, estrogen, LH, and progesterone. And so with this, a woman can actually find out whether her ovulatory cycle is normal in terms of, let's say, yes, is the follicle growing at the right rate? Is the LH surge happening? Is the LH triggering? And then she can use that to identify when to time the intercourse. Is progesterone rising? Is the progesterone level high enough, to support implantation? All of these things can be done with our product. But of course, there are a lot of gaps, you want to also do imaging at times, because what really is happening in the body is a little different from what happens with the hormones. But yes, a lot of companies, not just us, but even wearables, they're trying to identify what information and insight we can give these couples, right? And not just women, but even on the men's side, we are looking at developing sperm tests which will measure the concentration of motile sperm, and you can use that to provide information to couples and see whether there's a male factor and so on. So different parts of these we are able to capture and provide insights. And I think overall, as we develop more tests, there is more opportunity for couples to see, hey, is my cycle already starting to have problems, which means maybe I should think of escalating treatment, or, I have more time and so on. So there's more power to the user. There's more decision making that they can use. They can share it with the doctors, and then, with the joint consult, they can take decisions together. So I see there are a lot of opportunities here.
All right. Thank you so much. Before we go to the next round, a round of introduction to Anchita herself. Anchita is a young PhD student, a first-year PhD student in the Department of Developmental Biology and Genetics. And this is all her brainchild. She chose this topic, she chose the speakers, and she's put up a whole fantastic list of questions for all of you. She's also going to see if there are audience questions that come up and keep us ticking as part of it. My question, though, at the very beginning is, how much does stress contribute to any of this? And as Malini mentioned, there's working people, they work at night, circadian rhythm has changed. So how does stress affect reproduction?
So you want
Dr. Lavanya, if you can comment on it.
Yeah, I think the stress is the biggest culprit, and the biggest culprit which cannot be broken. Because I always say it's easier said than done. Whenever we are talking to our fertility patients, of course they're going to be stressed because they're not being able to plan a pregnancy or whatever, any reason anybody would come to a hospital. That means they do have a problem. That itself, entering a hospital itself is a stressful situation. And be it anything nowadays, I think the younger generation, I will not say kids, but younger generations, we see the smallest of the thing, the way another generation took it, and here smallest of the thing is like big for them, and to solve them is all difficult. So stress is something you learn to cope with, is very important. And like I said, it's easier said than done, because it's all about how are you going to take it. So whenever there's a stress, the adrenaline, the noradrenaline, everything that's getting released from your pituitary is going to go into every organ. You cannot choose and say, hey, look, this is the traffic stress and nothing to do with my fertility, or this is my month end or the year end stress that I have and has got nothing to do with my home or my pregnancy or nothing, or this is the mother-in-law, this is nothing. It's all going to get affected into every organ of your body. Forget fertility. This is why people end up having cardiac disorders, heart attacks, strokes, hypertension, diabetes, which in turn becomes a basic factor for all the medical disorders. So I think stress is something very, very much needs to be addressed, irrespective of be it fertility or non-fertility. And like I said, they are going to affect, because especially because we are talking about reproductive medicine and me being a fertility specialist, They do affect, for me, in terms of quality of the oocytes, quality of the sperms are majorly affected. We see people, fertile people, when they come, we have like I said, it's all about self awareness and keeping things under control. When we have a couple with similar parameters, be it the good sperm, good oocyte, and the other end same but stressful couple, and somebody who's like, doctor, fine, if it happens, fine, if it's not happening, it's okay, they end up having a conception in a shorter duration compared to a couple with the same parameters but very stressful, very anxious, and say, doctor, I want it within this month, why am I not conceiving? So this is where we see clinical terms. I mean, of course, if we had a psychologist on the panel, they would have told 10 by 10, 9 by 8, and their stress level is 10 plus by 10 and all. But for me, I see that in the reflection of the oocyte quality, because I said I'm a fertility specialist. That means I'm literally seeing the oocytes under the electronic microscope. Oocytes are big, so I see that then they're not having a 2pn, or there's so much of problems, how the sperms are looking, everything is reflected. And stress, even post fertilization, the embryo qualities, the number of tubes that I'm going to get, number of matured embryos, everything is related, because it is going to affect the chromosomes as well. And yes, stress also leads into a little higher chance of abortions, implantations are lower. So definitely I would only say yes, stress is a major factor, not fertility, for everything. So I think we'll have to start working on our stress levels. How? Yes, through the day, I think we will discuss on that. Not easy though.
Over to you, Anchita.
Yeah, so in similar terms, so as we are discussing about stress, so we are discussing about circadian rhythm. So in general, so the lifestyle has also changed a lot in today's generation, be it food habits or circadian rhythm, as already mentioned. So how do you think, Dr. Malini, these lifestyle changes would affect it would lead to lifestyle diseases such as PCOS or type 1 diabetes, and how would that be affecting or worsening the reproductive aging more?
You said two things. One was circadian and one was the food habits. So in food habits also there is one more thing. Okay, it's not just the food you eat, but the time of food you eat. So circadian clock is not governed just by light. It's also governed by the time of eating. These are called as Zwitter this thing and Zwitzberg things. And so light, time of eating food, time of exercise also. Earlier days, people used to exercise in the morning, right? Now, I have not seen that much in India. Maybe Bangalore it is there, but in US, you can see people running in the daytime because they are running time. They are running in the daytime, odd time. So there is a time for everything. There's a saying in our Indian old thing, like you should do things on time. So that affects. So the circadian genes, they regulate all the other genes in our body. And how it would affect is what actually we showed was that it changes the conversion, increases the conversion of testosterone. More you will find higher testosterone and higher DHT, which is one of the major things in PCOS. So just a change in circadian rhythm, if you take an animal, change the circadian rhythm, you can get PCOS. You don't have to do anything else. Now, one of the targets is NAD pathway. And NAD pathway has come up very big in longevity as well as reproductive aging. So there's a person who has made a assay kit. I think Varun should take the cue from me because you cannot measure NAD at home easily. So there is a scientist in US in whose lab I have actually worked earlier as a collaborator. He has made the NAD in-house kit, like you send, but the sample has to be sent back to him. So to measure, if you can measure NAD levels, people have shown there's a very nice cell paper where you can, if you give NAD, you can correct ovarian aging. You can increase amount of good ova being formed. This is all very new literature which has come up. Regarding PCOS and NAD, well, I have data about it, and we know that PCOS also has low NAD. So I think longevity and aging both have to go in sync together. Both are, same coin in one, like aging versus longevity, right? And the quality is important. So PCOS has, and type 1 diabetes is different, but I would say type 2 diabetes would get more affected, because type 1 diabetes is an immune disorder where the beta cells are under autoimmune attack. But type 2 diabetes develops like PCOS, and in PCOS women also you get type 2 diabetes. So this is all, and there is a large study with several million people taken into the study where they show a circadian derailment, and many other factors are involved in that. So PCOS women have more incidence of diabetes and insulin resistance. Therefore, it's important, to, like, you have to sleep on time, eat on time, and as Dr. Lavanya said, stress. I think even we parents have been responsible to put stress on the younger generation. We had too many expectations probably from our children, and not only we as parents. I think sometimes teachers have more expectations. I can give you a case where my daughter, she came back crying when her 12th result came. When I came home, I asked what happened. She said that she got 100 out of 102 papers. In the third one, she didn't get. And the school expected her to get. So that is the kind of stress we are putting on the children. So I told, I never got 100 out of 100. It's okay. I've become a scientist and doing pretty well. So no need to bother about this mark. So I think our younger generation is put to stress from childhood. We send them to tuition because everybody goes. So everybody goes, and I don't know in Bangalore, but in Kerala, they go for tuition at 4 o'clock. So you start derailing their circadian rhythm when they are in fourth class, fifth class. So I think we also, means before they got work stress, we as parents and teachers have put a lot of stress on them, which we have to kind of try to reduce.
Yeah, thank you, Dr. Malini. So shifting gears, let's talk about the modern techniques which are there to combat reproductive aging. So there are a lot of techniques related to stem cell therapy and egg freezing that have been developed. So Dr. Lavanya, what is your take on this?
Now if you ask me to talk about stem cell, then I think the whole entire session you'll have to give me, because I'm so passionate
I think Anna
about
can
it.
also join if in
Yeah.
case of stem cell.
This could be a topic of its own, I agree.
Yes.
But please go ahead and tell in brief what can be put.
Yes. So definitely, see, we all are talking about changing our circadian rhythm. Malini spoke so well about what is happening, but then how easy is it to change? Not at all easy. Yes. Even as a parent, you take that decision that you want to change, but your environment of your surrounding, the thing that the kid goes through, and be it an adult, your office, lot of things. It's like I said, it's always easier said than done, and this is why I said stress treatment is trying to cope with that. What are the modalities? And again, not easy at all. So when we are in a world like you're in an ocean of stress, and then how do you deal with it? It's difficult, because coping up is also not going to be easy. That is when all the medications come into the pool, other than, and this also I would try to say, when it is stressful, that is when you're getting into a lot of habits like smoking, alcohol, drug abuse is increasing, and making the entire process more worse, pushing your fertility, all your hormones, everything, be the male or the female. And we are following the West for the worst of the reasons, and it's going to make it only worse, these addictions. You're thinking, this is, go take a fag because I'm going to look cool and I'm going to be like among this. And it's common with the girls as well. We see, I'm sitting in between a IT hub at Electronic City, then we see it's very common. Or rather, now on the streets when we are driving, I see more of girls smoking, and a lot of these things does definitely affect. They are thinking it's a stress relief, but then it's making your body go into more, hormonal balance is going haywire. But this is all the habits that we need to change, which is going to take a long term. We're talking about meditations and calming, breathing exercise. How many of us are actually doing it? How long are you doing it? So many things. I mean, of course, since I'm not the expert of the meditation, I'm more the expert of the medicine. I would like to talk what we could be doing. So that is when our role comes in. She was talking about NAD, that is the nicotinamide and all. So like that, similarly, we have coenzymes, we have leucine, we have selene, we have zinc. Lot of these things does act. What is the problem here? Be it the stress or be it the age, what is affecting is the telomerase. And automatically telomerase starts becoming shorter as the age increases. Now these insults that you are adding, either with an abuse or your stress or your circadian rhythm or the PCO, any of the medical disorders or the any of the lifestyle, worst of the lifestyle things, is only reducing your telomerase to a greater extent. Now we cannot do anything about it because that's a physiology. But then how do you break your physiology, or how do we can't halt it? I always tell my fertility patients, I can play God, but I cannot become God. We can try to an extent. So similarly, we can add all these medications, like I said, all the coenzymes, everything, leucine, everything, to stop it or improve it a little bit. But again, how much is getting absorbed? Are you taking it the right time? Because a lot of medication also comes like you take it at a specific time because it matches your circadian rhythm. Now I'm going to tell, okay, please take it before dinner and then done. I'm not even asking her, are you going to go sleep after dinner or are you going to go back to your office at 10 o'clock? It doesn't match. Because for me, and my traditional thought is post dinner, you're going to go sleep. Now, myself, I'm coming back at 2 o'clock for delivery. Then if I'm sitting here, then I know a lot of people have a night shift and their day starts at 10 o'clock. So again, that's not matching. And this is the reason why each medicine has a particular time. So medication, we cannot rely on the absorption and its implementation on the organ, the end organ. And any medication we take, it has to go through your stomach, get metabolized in your liver, kidney, and then goes to the target organ, which is not going to be proportion of what you take and what is reached in the end organ. That is when the effects of the stem cell comes, the effect of the PRP comes. Now, stem cell, we have to remember, it's a primitive form of a cell. And these can form different kinds of specialized cells, like 200 different cells. Now, in the short, because I know we're talking to a lot of public people who are attending these things, it's simple. Like I put it into a skin after the processing, it should form a skin tissue. I put it onto a hair, then it would form a hair follicle and let the hair grow. I put it into a cardiac, then it should form a cardiac muscle. Now, the same thing, I put it into an ovary. My expectation of a stem cell is it needs to create an ovarian tissue. It also, the whole action of the stem cell is like to increase the new blood cell, which we call it as a neoangiogenesis. Then I want it to act where the AMH. AMH is an hormone which will tell us about the quality of the oocytes, the age of the ovary, and as well as the FSH is used for the similar reasons. Now I want my AMH to increase and my FSH to come down. And these stem cells have growth factors where they're increasing all these things, increasing the blood cell, increasing a newer tissue. And I'm hoping these new tissues form better quality of oocytes. I do a lot of work on stem cell. I started my work with platelet-rich plasmas, and then we moved on to stem cell. Now I'm in the transit for exosomes. Exosomes are much bigger than the stem cells. So we are getting the first of the South India machine very soon, maybe in a month or so. And next we can talk about exosomes and not stem cells. So anyway, so the stem cells work in the mode of a growth follicles or the growth factors, which will improve all the quality and improve the environment for a better sperm quality, better egg quality, where we are taking these from the bone marrow. We could take it from the embryo, but then we have a lot of issues of ethical issues, a lot of these. So the easier is it is an autologous. So you're taking it from the same person, we are doing the processing and injecting back. So we have done a study of more than 150. Our international journal is in peer review. I always say when I give it as an option, whenever they have either a previous failed IVF or the quality of the oocytes in the IVF has been bad, either they have no choice but to go to a oocyte donor. Lot of them would want their own progeny. They're not going to accept for a donor so easily. And now with the ERT laws, all the fertility laws, it's a little difficult as well. So then these are the options. So we don't say, of course, we tell it. I will not say it is an experimental procedure, but then of course, a lot of them more needs to be into this clan of doing this study on the stem cell. A lot of publication needs to come. It will take a little longer time to say, yes, it is effective. But at least personally, I would say I have seen an improvement in the quality of the oocytes quality of the sperms, the number of embryos we have got, everything is way better. And that's how I definitely appreciate. But I don't deny the fact that a little more scientific work needs to be done. And with IISc people, with all here, I'm sure a lot of things are going to come up in a positive way.
Thank you, Dr. Lavanya, for all those very insightful inputs. One of the queries that most people would have is, earlier people approached assisted reproductive technology or IVF clinics only when there was trouble. There is trouble either conceiving, that's when people would go. Do you think there is a surge in the number of younger couples now who want to put career in front of everything, coming to you and asking, can they freeze their eggs? Can they freeze the sperms? And then postpone the childbirth to a later stage? Maybe they can make use of IVF, provided if they can freeze their eggs and sperms now. Do you come across people that come and ask these questions?
Yes, Anu, in a short, I would say yes, definitely yes. But then I would go one step backward than you and say, not only the young couple, I have a lot of young girls coming into the clinic and asking me, I want to do a oocyte preservation. This is how my practice has changed. Now, I've been practicing for the 19-20 years, and I see a lot of shift in my own practice. In the last month, you won't believe, I had 3 girls, one 28 years, one 31 and one 32, walking themselves and saying, look, my parents are forcing me. I don't want to get married right away. And I want to postpone my marriage for another 4-5 years. And I'm not sure when are we going to plan. So can I do one oocyte preservation? So I think a lot of platforms like this, technology is of course a double-edged sword, but then people are becoming aware that the egg will come down. Like I said, the Down syndrome chances, chromosomal abnormalities are going to increase. So people are becoming aware, and they also know a concept. There is something that where they can preserve an egg. So we are seeing a lot of this trend change. Whoever wants to postpone their pregnancy, they are also increasing, other than the young couple. Now, yes, a lot of people who are married, young couple, they walk in, and doesn't have to be young couple. I have seen my clinic trend where the mean age is 35 years. And even at 35, I have couple married for 1-2 years, 3 years, and they come back and say, doctor, either I have an opportunity to go outside the country, or because I'm in this position, or for umpty number of reasons, they don't want to plan for another 2 years. Then they say, look, we want to go for egg preserving. Then I tell, if it's a young girl without a partner, yes, definitely we need to go for an egg preservation, which we call it as a oocyte preservation. And also extremely well for cancer patients, because with the cancer treatment, I think the lifespan has increased. So they all are going to reach a reproductive age group where they are going to become a parent, and either because of the stress or an anxiety, majority of them don't talk or don't venture into talking about egg preservation. And even the semen freezing is something very important that to be done, so that you can use it decades later, years later, when they are good to go ahead. And I think that's something that we have to do. I'm also trained in ovarian tissue preservation from Denmark. So we work a lot on cancer patients in oocyte preserving, sperm preserving, and ovarian tissue preserving as well. Now, if they don't have a partner, yes, very good. You preserve this oocytes, and sperm preserving is very easy. Ovarian tissue is a little difficult. You need a technical skills. Now, but if somebody is already married and have a partner, I also have quite a few couples who are in live-in, and they say, we want the oocytes, and I tell them, look, if you have a partner, the survival rate of these oocytes when we freeze and thaw is much better when it is fertilized, when it's an embryo. So we say, if you have a partner, please, let's go ahead and form an embryo and keep it, because then the survival rate when we bring it back is more better. So it goes on the options. Do you have a partner? You want to freeze it with this partner? And now we also see different partners, and it's all become a very common practice. So we have to talk, take the consent. And yes, like I said, in a single word or a single sentence, I have to say definitely increased. Not only young couple, lot of young girls or single women are coming into the clinic asking for oocyte preservation. And this is only going to be increasing, and we call this as a social freezing. So where we want to stop the clock for them, so that the egg which is preserved at 30, even when she comes back 4 or 5 years, she could be 35, but then our egg and the oocyte are still 30 years.
That's right.
So everything chromosomally, everything is over 30 years, and then we form the embryo. So our success rate would be much better.
Amazing how technology has made us think about all these things also. Continuing along these lines,
So let's move more towards technology. So it's important to discuss about what in today's world, how artificial intelligence can play a role in the treatment personalization. So Mr. Varun, what do you think about how does data science and imaging play in advancing the fertility monitoring?
Yeah. So I think there's a lot of work happening with fertility and AI, but yeah, given my knowledge with respect to diagnostic tools, I'll just limit it to that. So what we've tried to do is not just make a product that gives out the hormone levels with robust quantification, but also we want to make it affordable. And so, with in the diagnostic space, you have a lot of different technologies that have been coming over the last several decades, like for example, microfluidics, nanopore sensing, and so on. However, none of these have achieved the kind of scale of manufacture and the affordability in terms of costs. So what we did was we used an older technology called lateral flow assays. So your pregnancy strips, right? They're very cheap. You can manufacture them in almost the billions very quickly and so on. But they are like kind of yes/no tests. And so we used imaging and AI to make them quantitative and also reliable. What this means really is instead of a yes/no, output, you give a number. So which means that there's a lot of calibration that goes on. Also, there are like flow defects and other artifacts that come on these cheap tests. And so that's where we use, high resolution imaging. Once you have a high resolution image, you can now use all the state of the art deep learning algorithms to identify all of these issues. Now you have a lot of data. For example, we have close to about 20 million data points of fertility, right? That's spanning over, women from the age of 21 all the way to 45. And, these are across several cycles. And so all this allows us to train better models. And then from these data points, right, of hormones, we are now able to predict the fertile window. For example, can we identify a very tiny LH surge, which is of significance, or a large LH surge, which might not lead to ovulation? Or can we find out is the progesterone level adequate enough to support implantation? All of these things can be done with deep learning if you have, high resolution images, which will give you high fidelity quantification. And so we've been on that exercise and it's been really fantastic. And so, for example, now we are going to expand it to building home tests. And one of Dr. Lavanya's favorite, I think, beta HCG test is something that we want to like embark on and so on. So there are a lot of opportunities. And that's the goal that we're going behind. Now, all of this essentially, again, will, help women identify, both couples actually identify what's happening in their body and then go to doctors and then identify whether, embryo freezing is a good idea and so on. So there's, I think without AI, really, a lot of what we do is actually not possible because traditional algorithms, which, your classical imaging algorithms would have never given the performance because, every test strip that we sell, if let's say we are giving a wrong result, that's a problem. Or if we are, invalidating it, that's also loss of money, right? So we don't want to get there. And for us to build a home test, right, as opposed to a lab test. For example, let's say you send your sample to the lab and then the test fails, right? They still have some more amount of your sample, and so they can rerun the test. It's not any hassle or any cost. But like at a home test, if you have a failure, then obviously you're giving out the wrong value, and a lay user can make a lot of mistakes, right? And then they'll end up getting wrong results. So you want to make all of this robust, right? So we are looking at getting like 99.99% reliability. And all of this essentially is just possible because of deep learning. And so the future, not just if we're talking about diagnostics, I see like a tremendous value, but I'm quite sure with example, like people are using AI to make robots that can guide the sperm, all right, into the oocyte, right? Proteins, really. And all of these are AI generated. So again, in the future, we're going to have a lot more very interesting innovations here. And Dr. Malini, I think thanks for this suggestion. I'll check that marker out.
Mr. Varun, if I may ask you, how far are we in this field of reproductive aging or the issues that we are facing today from having a continuous glucose monitoring kind of a wearable with which somebody can, figure out over a period of time, well, this is just begun and probably the decline is just here, and therefore I need to probably rush.
Yeah. So first of all, to actually know whether you need to rush or not, you don't need continuous monitoring. You can essentially look at a single test a day and it would work out. But let's say if you think that is a hassle and we need, and I could imagine some people saying that, okay, let's go ahead and do continuous monitoring. This is still quite challenging because if you see your glucose monitor, right, your continuous glucose monitor, like your Freestyle Libre and all that, they've spent like several decades of innovation, and still we have only one marker, which is your glucose, that's being measured. And also it's kind of fortunate because your interstitial fluid can kind of approximate your blood glucose level. But when you start looking at all the other markers, right, the correlation is actually low. So even if you could really make that gadget, right, it has to draw your blood level and not your interstitial level. And I think we are quite far from that. It would be great if there is a way that we could indirectly measure. But again, when you're taking this through clinical trials and all of that stuff, I would say nothing earlier than 5 to 10 years where we get to something that way.
So, Mr. Varun, I also have a question since you are into diagnostics. So, I think one of the major problems which the infertility agencies, clinicians face, and Dr. Lavanya can correct me, whether it is PCOS or anything, the whole thing finally comes to implantation. So we still don't have a very good test for implantation. I have worked, I think, 30 years on implantation. The Indian map is still not there. I have kind of generated some of it now. But because whatever is available is the Carl Simon's one, which doesn't translate to our Indian subjects thing. So one of the major challenges I would say I faced during my 30 years was to get those samples, the biopsies, to even make the map. And then, how far do you think can AI help in that? If one had images of the receptive uterus, and can one think of trying to utilize that?
Yeah. So prima facie, I've not seen these images, right?
Yeah.
And it will be too premature for me to comment on that. But if you are able to look at these images and make a distinction, I'm quite sure an AI would be able to do much better. And so early on, all these algorithms were not as good as the human, but now, across different modalities, they have shown that they can outperform humans, right? Because they try to identify those underlying patterns which our eyes and brains are not really able to capture. And so I think it's a good try to give it to an AI, neural network and see what you're getting out of it. But if you're able to do it, then definitely it should be able to do better than what we're doing.
Okay.
So I would only say that
we
AI
have
is...
some questions from
Go
the
ahead.
chat box.
Yeah.
So there's one question that talks about how CRISPR technology might be useful in reproductive aging. Dr. Malini, would you like to answer that?
I wouldn't think in that way, because reproduction is a very complicated thing. So it is not just one gene, right? So that is only applicable if somebody has a defect in one gene and you correct it. But during aging, it is not that you will be knocking off all the genes. So I wouldn't say that that would be the main challenge which the infertility specialist would want to address. Because you should do work also which is more useful. So what the clinician is looking for, I think, is should be more our thought process, and focus.
Yeah. So
Yeah. We have another question that talks about how have COVID affected this reproductive aging? Has there been an effect? So do you see any surge in cases post-COVID? Dr. Lavanya, I think you're the best person to answer this.
I think COVID has again played double-edged sword. So one way it is told that family is definitely important. So while we all were like, all inside the house, then you realize the value of a family. So you need to have a family. So we've had more couple asking like, okay, we need to plan a family. Post COVID, I've had a lot of couple who came back and said, look, we never wanted to have a second child, but then now we are planning for a second child. Or couple who said, we don't want to plan kids, we want to plan kids. And again, on the other spectrum, like I said, double-edged sword, on the other spectrum, we've had people coming and saying, oh, we are all so short-lived, why worry about all the children and these things? So we have quite a few couple who say kids are not on our plan at all, and sometimes I play the granny role or the mother-in-law. Why you're not planning pregnancy? You're already this many years married. And quite a few couples say no, a child is not on the card at all, we are not planning for pregnancy. Or quite a few say that not as of now. That's when we talk about preservation. So yes, COVID definitely has changed a lot of logistics for the couples as well. But coming in terms of the quality of the oocytes and the sperms, I think it was easily observed in sperm parameters, where immediate COVID, we saw a decline in the sperm parameters in terms of morphology, motility, a lot of things. Even the count had quite drastically changed. So it does bring in an effect. But in the oocytes, it's very difficult to study. It's a complex thing, and not like women in themselves are complex. So even so is the oocytes, where it's not easy to study. So it takes a longer duration. But yes, the quality of the eggs did change. But now, like I said, there are multiple factors. Now, over so many years of COVID, we can't just blame the COVID virus, or some people talk about vaccinations, but we also have to understand it's each one's lifestyle. So like I said, a lot of these smoking, alcohol, drug abuses, your environmental effect, your laptop uses, most of them working from home, though now you have hybrid. Where is the laptop? Typically followed on the lap. Correct? And where are your mobiles going? On your pant pockets, be it the girls or the boys. So these radiation effect, your Swiggy, Zomato delivering lot of preservatives to your home, and they're also causing gene mutations. Correct? So it is a combined thing. So you cannot just blame one factor and say this is the factor which is caused. So overall, we have seen a decline in the quality of the oocytes and the sperms, and that is very important. To your previous discussion on AI, I will only say AI is going to penetrate into every bit of it, every nanoparticle. So it is already there in terms of fertility. You were asking, Varun, how in the reproductive, we have embryoscopes where that's all AI, where, otherwise, what are you doing manually? You're checking on the day 1, you're checking on day 2, and you're checking on day 3 or day 4 and seeing what has happened. Now your embryoscopes or your AI, they are going to show what all changes happen, why one was a better embryo or why one was lesser, where there lacuna which has got overlapped over day 3, day 5. So we are seeing that AI is helping us pick up the best of the sperms. Now AI is where we are also trying to do gene testing in the embryos and saying, is this a euploidy embryo? Is it an aneuploidy embryo? That means, is it a good embryo or is it a bad embryo which has got chromosomal defects? And if we have implantation failures, we were talking about implantation. Now, again, that is a very controversial topic, because we don't have a precise test to say, yes, this is where it works. That is when I played God and I cannot become God. Playing because you're creating a life outside your body in the lab, where you're picking up the oocytes, sperms, and doing. Now, if I don't check these embryos, I don't know, are they chromosomally normal or abnormal? This is what we call euploidy and aneuploidy. Now, yes, we do have gene testings done on these embryos and say it is good. Now, if I have a good embryo, that is an euploid embryo, and I put it because of my scan measurements I did, and the blood flow is good, the lining is good, then it should be 100%. It's not happening that way. So that means implantation rate itself is much lesser. Now, what do we have to do? Of course, it's a debatable topic. We have endometrial receptivity test, again, not proven, where we take a part of the endometrium, send it for testing, and they say this is the receptor. But why it is not precise? Because I'm checking this month, but I'm doing my embryo transfer next month. How are the receptors changing? It's going to be completely different, because the uterine lining is a dynamic process. So there is no precise test for implantation, but then this is how the whole thing will happen. This is why AI, and I feel in the future it is going to be biotechnology is going to be a wonderful subject. Genetics is going to be something which is going to be looked in, because everywhere we need to take. And technology, if people like Varun and his friends and his teams are there, it will happen, because I've been their clinical partner and we have worked aggressively, and I know they have such intense knowledge where smallest of the thing they want to get it right, and I say I do a scan, they have always correlated. And it's a time, and the patients, Arun, has it taken more than 8-10 years now to be where you are? Yes.
Yeah,
So
it's
something being persistent and persevering and continuing. It's like our own, medical education. It's same for them, getting updated, what is happening and being there. Do you also need to have a patience to help the AI get into it and give you a precision is what is more important here. So.
Yes, ma'am. So we have other questions also. So one question is about what are the earliest biomarkers of declining fertility. So I think this is something which is a very common question in the scientific academic research field, because be it anything, for all kinds of diseases, we are always searching for new protein or biomolecule markers. So do you have any idea about declining fertility markers, some proteins that might be upregulated or downregulated, Dr. Malini?
Yeah, so in the female system, in the implantation time, people have identified some markers which are critical for a process, like say implantation. But the endometrial receptivity array is actually a map of some 300 genes. So that is what they look at. But then similarly in sperm, you have for sperm quality, like fertile sperm, there are papers on proteome, molecules which are critical, and people are trying to make arrays to judge that. I know some scientists who are making protein arrays. It has not yet reached probably the society, but they're trying to make protein arrays so that the clinician can use it, because sometimes in unexplained infertility, it looks that there is no problem, but actually there is problem with certain proteins in them. Similarly, like I'm trying to make the endometrial receptivity array. So the proteins important for endometrial receptivity. And one thing which you introduced me for, which actually people never thought, was the free radicals. People always thought free radicals are bad, but they are required for implantation as well as fertilization. And I think we showed it in 1990. Now Western world is also showing it. And the fashion of, reading TV and eating antioxidants to stop aging and look beautiful is not a very good idea. Till the clinician prescribes it, one should not use it. Many clinicians came to me in Delhi and all that. They were giving antioxidants, but they didn't have success. We had shown long back that if you give antioxidant, implantation doesn't occur. And there is one UK, Professor Atkin, who has shown its role in sperm fertilization. So some things which we all did till now, and food, she said, right? So food, the Swiggy food, it has a lot of preservatives. Preservatives are what? Lot of antioxidant is there in it. So we have to be careful on what we eat. I see one question on time of eating also. Somebody has asked that what time should they eat food. Definitely not 11 o'clock or 12 o'clock in the night. You're supposed to eat before 9 o'clock, because 9 o'clock melatonin rises and cause you to sleep. And daytime also, it should be around 1 o'clock. 12 to 2 you can understand, but not at 4 o'clock, 3 o'clock. Suddenly you get up from work and order food and start eating. So those are the issues which are like, so a lot of parameters have now come into play, which earlier were not there, which now the clinicians have to deal with, the lifestyle disorders. So yeah, there is an effort. Protein biomarkers are there for sperm as well as endometrium. Oocyte is very difficult. Even with mouse oocyte, it is difficult to get those many oocyte. To create a map is very difficult. For me, the challenge I faced for the endometrium was, if I get one biopsy from a patient, I cannot go back to that patient and tell, give me more biopsy for my research. So I made endometrial organoids. so that then they were in culture and I could use them again and again to test the thing.
Yeah. So in similar lines, I think we have answered this question all the more, but okay. So there's a question, can personalized nutrition based on genetic, metabolic and hormonal profiling be used to optimize ovarian health and delay reproductive aging? So it's basically how lifestyle would be affecting reproductive aging. I think we can answer that question and maybe conclude the session. Dr. Lavanya, what would be your take on that?
Definitely. I think the good food has its own advantages and definitely it has an effect. But then everything we always say, even Amrita, when you take too much is bad. So you'll have to balance out on what is right. And, like I said, meditation, breathing exercise, good food, it is not only about food, or it's not only about exercise, or it's not only about stopping your habits, or not only about one thing. It's about mix of everything, including like how she was talking about a sleep pattern. So smallest of the changes and walking towards making a conscious decision to walking towards the right health is what is more important. And what is right to me cannot be right for somebody else. So try to figure out what works best for you. Now, for a South Indian, you come and tell you have to eat chapatis every day. It's not going to work. Now you go to a North Indian and say, oh, rice has got its own advantage. So it has to be catered accordingly. So just walking towards the right health is what is more important. And in short, for the ovarian aging, of course, there are so much of omics, proteomics, and all these things working on the male and the female. Female, we can use something called as an AMH and an FSH, and just not only on the biomarkers, but also doing a scan, checking on the antral follicle counts, are all something that we can work towards. It's a multiple parameters, and like you cannot just take one hormone. Just the AMH is not going to mean anything to me. Doesn't matter whether it's very high or very low. Now I need to check it with the FSH. FSH going very high, AMH reducing. Then I'll say, hey, look, your clock's ticking faster. You need to work on either preserving your oocytes or go and find that perfect partner and plan your pregnancy today or at the earliest. Now, only two parameters. No, I'll have to also check on my scan and see, is my antral follicle good? So like this, multiple parameters, even your lifestyle modification. When we say, I always tell my patients, look, when I say lifestyle modification, it's not only about your diet, it's about your diet and exercise. So I think it's a holistic healing that needs to be focused, and not just only the clinician or not only a physiotherapist or not only a Ayurveda or a Ayush or a homeopathy or just the technology. It's a holistic healing with all of us together is when we can achieve the right path for our patients who are seeking the right health, be it the reproduction or not, is what I would say and conclude with.
Yeah, thank you, ma'am. Mr. Varun, there's a present question from one of our audience. So it's about, is there have been any recent advancements in surgical devices or procedures aimed at improving ovarian balance?
I think I'm not the right person to answer that.
So surgically, I think, like I said, stem cell is the latest one where it's moving on to exosomes as well. So this is one of the latest one which is working on the ovarian kind of anti-aging. I will not put it that way, but then definitely trying to halt or work on preserving your oocytes and the sperm. So even this is used, but I have not personally had good experience on the male factors, but definitely working well on the oocytes.
Anchita, could we have a last concluding round from all the panelists? And as a take-home message also for the audience?
I think this session is to be concluded. Yeah, I don't think there are any more questions from the audience. Okay. So Ramya wants to ask, what does the future of diagnostics look like, combining circadian rhythms, biomarkers, and AI? So yeah, let's take the last question from Dr. Suramya. So just to introduce to the audience, Dr. Suramya Asthana, she is the lead coordinator of Longevity India Initiative, and she's the person who is handling everything related to Longevity India.
She's the force behind this.
Yeah, she's the force.
Suramya should also come online and show up.
Yeah. So
Hi, thank you so much. I just wanted to ask that since all of you are here in this room, we have a scientist, a clinician, and a technologist. Like, what does the future look like? What's the demand of a scientist to a technologist and ultimately a clinician in
So
terms of diagnostics and aging?
let me tell one thing, Suramya. All the circadian rhythm data has gone into making all those Fitbits which have the sleep thing. So there's a scientist called as Dr. Walker who worked along with Google. He was a sleep scientist, and that has led to all these things uh, coming up. So that's like a core research, basic researchers finally associating with Google. Here, like we are trying all to associate with Varun to have better things. So a combination definitely with circadian biomarkers, AI, and the clinician input. I think something which is lacking in this is the clinician input that is critical for taking it ahead.
Varun, would you like to answer that?
Sure, sure. So I think on a daily basis, the things that we do the most is probably interacting with apps, right? And then we log everything into it. And especially, for example, if you're health goal driven, which a lot of couples who are facing infertility, right? I mean, in our app, we've kind of allowed them to log their symptoms, their basal body temperature, and really anything that we add, and they can think of it, they want to just log it up. So there's a lot of data that people are entering, and then of course you have sensors like your watches and then your thermometers, all of these things, right? Rings also. So there's a deluge of data, and people are looking for how to start getting insights from this data. But then there's also the research and clinical angle. Like, for example, Dr. Malini was talking about, hey, can we have a marker for implantation, really, directly or indirectly? And so you want to combine all of that. And so that's the work where I think between the research and technology and scientists and even entrepreneurs, right? That's where the focus is going to be, right? You are having a lot of markers. Some markers are missing. So let's say, how do we now build assays or measurement devices to fill those gaps? And then after that, kind of say, okay, how is the AI going to now process this data? There's also this matter of ground truth and data privacy and all of that stuff. But I'm hoping that we'll slowly overcome that. And then it's going to be about insights. For example, let's say if Dr. Lavanya is going to look at a lot of the activities of the patient, you want an AI to actually make the data in such a way presented that she can actually take actions on it instead of looking at a large amount of unnecessary data and so on. So to condense data into insights is one activity which people will be working on. Identifying these key gaps, right? That will be another action item. And of course, democratizing testing. Like, it would be very nice if you can get like a continuous monitor, and you just you have a patch and all the data comes in, and then you have an AI that's looking at it, doing the inferencing, and then saying, okay, these are the key events which are important and so on. That's a direction where everyone is going. And so far, at least in our case, we've seen that our users have found it very, very useful, that we are mining their data and giving them inferences. It's personalized, it's actionable, and so on, right? And I think the broader community is also going to do it this way. So.
Yeah, thank you so much. Dr. Lavanya, I think you have something to add.
So, yeah, and I was saying, this is why when I mentioned we are looking at a holistic thing, we're coming with something, it's named as Zoria Care. So where we're looking at a holistic healing, where we're trying to combine a clinician being there. We're also trying to work with several other medical specialties, not just the allopathy. Like I said, everything has its own advantages and its own disadvantages. Also bringing the technology into the whole thing and trying to make it like a holistic thing is what is more important. I think that is where we all are going to fall in place, and we're going to come in a peaceful platform where like the end result is what matters. So that's why I said, holistic healing, all of us joining hands together and working and helping our patients carry home the bundle of joy is what matters. Everybody's contribution is equally important.
I think that's a good note to end this presentation. Anchita, would you like to make a concluding remark and end the presentation, end the webinar?
Yes. Yeah, so I thank all the panelists, our moderator, and all the audience who joined us for this session. And I think it was a very enriching and engaging webinar. And hope to see you all soon with a more interesting topic next month. Thank you so
Bye-bye.
much.
Thanks to you,
Thank
Anchita,
you.
and
Thank you
Kiran,
so
for
much.
putting it
Thank you.
together.
Thank you.
Thank you, everyone, and Anu also.
Bye, bye. Bye. It
Bye.
was great
Yeah.
meeting all of you. Bye-bye.
Yeah. Bye-bye.
Thank you all. Thank you.
Thank you all. Bye bye.